Hi everyone, and welcome back to part 3 of the renal system. In this section we'll be looking again at renal physiology, starting with tubular reabsorption. The glomerular filtration rate of 125 mL per minute means that in 30 minutes 3.75 litres of fluid will be filtered into the proximal convoluted tubules within the kidney. As the total plasma volume is 2.2 litres, it is obvious that in order to maintain plasma volume, a large quantity, approximately 99%, of the glomerular filtrate must be reabsorbed by the renal tubules and the collecting duct. This can happen by diffusion, which is passive movement from areas of high to low concentration, primary active transport, where energy from ATP is used to pump substances across a membrane, or by secondary active transport, where energy from the ion's electrochemical gradients drive another substance against its own electrochemical gradient across a membrane. This may be either via symporters, which are proteins that move ions in the same direction, or antiporters, which are proteins that move ions in opposite directions. Within the proximal tubule, 100% of most organic solutes are reabsorbed. Glucose and amino acids are also reabsorbed, along with 80 to 90% of the available bicarbonate ions. 65% of the water, along with sodium and potassium and chloride ions, are also reabsorbed, along with a variable amount of inorganic ions. In the loop of Henle, 15% of available filtered water is absorbed, along with a variety of potassium, sodium and chloride ions. The ascending limb of the loop of Henle has symporters which actively transport 1 sodium, 1 potassium and 2 chloride ions per symporter, and this is an ATP dependent process. The cells of the ascending limb of the loop of Henle are almost impermeable to water. About 20 litres of fluid per day enters the collecting ducts, but only 1 to 2 litres of urine are produced each day. 18 litres of fluid is absorbed through so-called principal cells which line the collecting duct, and this maintains blood volume. This is regulated by the hormones aldosterone and ADH, which we learnt about in the previous session. We'll now move on to tubular secretion, and this process removes material from the blood as either waste products, such as creatinine, urea or ammonia, or as a homeostatic mechanism, for example to adjust the pH or ion levels within the blood. Principal cells reabsorb sodium and secrete potassium, and potassium secretion is regulated by increased levels of potassium causing the adrenal medulla to release aldosterone. This stimulates the principal cells to secrete more potassium into the tubular fluid. High levels of sodium ions in the fluid increases the rate of sodium absorption and potassium secretion. Intercalated cells in the collecting duct have protein pumps which secrete hydrogen ions into the tubule fluid. Excess hydrogen ions can be excreted, thus reducing blood acidity. Chloride bicarbonate antiporters also allow the movement of bicarbonate into the blood, reducing the acidity. Hydrogen ions are also buffered in the tubule fluid. Regulation of tubular reabsorption and secretion is controlled by angiotensin II. As we saw in our previous session, it enhances the reabsorption of a variety of ions and water in the proximal convoluted tubule by stimulating the activity of sodium-hydrogen antiporters. Furthermore, angiotensin II stimulates the adrenal cortex to produce aldosterone, which enhances reabsorption of sodium by the principal cells and collecting ducts, so this increases absorption of water. Angiotensin II also stimulates the release of antidiuretic hormone from the pituitary gland. This promotes reabsorption of water from the collecting duct and allows the apical membranes of principal cells to become more permeable to water. It does so by stimulating the insertion of water channel proteins called aquaporin-2. When levels of ADH decline, these channels are removed by endocytosis. So in summary, the actions of angiotensin II include constriction of afferent arteriole, thus decreasing glomerular filtration, increasing the release of aldosterone, increasing the release of antidiuretic hormone, and generalized arterial constriction. The second hormone involved in regulation of tubular reabsorption and secretion is atrial natriuretic peptide. This increases glomerular filtration rate by relaxing the glomerular mesangial cells. This results in dilation of afferent arterioles and increasing surface area of glomerular capillaries for filtration. It also inhibits the reabsorption of sodium, and therefore water, from the proximal convoluted tubule, and it suppresses the secretion of aldosterone, ADH, and renin. So the final product, so to speak, is urine, and approximately 1 to 2 litres per day are eliminated in an adult. The volume will be influenced by blood pressure, diet, temperature, medication such as diuretics, mental state, and general health. Urine tends to consist of 95% water plus 5% solutes from cellular metabolism, and these include things like urea, creatinine, uric acid, and a range of inorganic ions. We'll now consider the production of dilute and concentrated urine. In the first scenario, if we were so overhydrated that we had no antidiuretic hormone, there would be decrease in the osmolarity of the extracellular fluids, and as a result there would be a decrease in antidiuretic hormone from the posterior pituitary gland. This would lead to a reduction in the number of aquaporin channels in the collecting duct, therefore reduced reabsorption of water from the collecting duct. As the water remains within the duct, there will be a large volume of dilute urine produced. In the second scenario, if we were so dehydrated that we had maximal levels of ADH, there would be an increase in the osmolarity of extracellular fluids. As a result, there would be increased ADH release from the posterior pituitary gland, thus increasing the number of aquaporin channels in the collecting duct. As a result, H2O reabsorption would be increased, and thus there would be a smaller volume of concentrated urine produced. This diagram is available in your textbooks, and it shows the different osmolarity levels at various stages throughout the nephron. So whilst you don't need to know these exact figures, it's worth remembering that the mechanisms that facilitate production of dilute or concentrated urine will depend on, firstly, the anatomical arrangement of the blood vessels and the juxtaglomerular nephrons. Secondly, the active sodium chloride pump and impermeability to water of the ascending limb of the loop of Henle. And thirdly, the level of ADH secretion. The loop of Henle and the vasa recti both have fluid flowing down one arm and back up the other arm, each being in close proximity. This allows for the development of a countercurrent multiplying system that produces high concentrations at the bottom of the loop. So as glomerular filtrate leaves the proximal convoluted tubule, its concentration of solutes is about the same as the initial glomerular filtrate, as reabsorption of solutes in the proximal convoluted tubule operates in tandem with reabsorption of water. When the volume of urine in the bladder exceeds 200 to 400 milliliters, stretch receptors within the bladder wall will send impulses to the spinal cord. These impulses pass along to the cerebral cortex and to the micturition reflex center in the sacral spinal cord. Stimulation of this center causes the detrusor muscle to contract and the internal urethral sphincter to relax. The cerebral cortex permits voluntary relaxation of the external urethral sphincter, thus allowing urination. An understanding of the renal system allows for several clinical applications. For example, we can have a greater understanding of the use of diuretics, which will slow the renal absorption of water. Caffeine will inhibit sodium ion reabsorption. Alcohol will inhibit secretion of ADH, and diuretic drugs will interfere with the mechanism for sodium reabsorption. In cases such as acute or chronic renal failure, the patient can be given dialysis. So where the kidneys are unable to function normally, the blood can be cleansed artificially. This uses a hemodialysis machine where blood will flow through tubing made of a selectively permeable membrane. Waste products are then able to diffuse into the dialysis solution. However, dialysis can never be as efficient as healthy kidneys, and dialysis patients will always have excess levels of nitrogenous waste in the blood. Disorders affecting the renal system include glomerulonephritis, pyelitis, pyelonephritis, and cystitis. This image shows kidneys that are affected by pyelonephritis. You can see the yellowy-white cortical abscesses around the kidneys. Other disorders include nephrotic syndrome, polycystic disease, renal failure, which may be either acute or chronic, and urinary tract infections. Diabetes insipidus is a condition where excretion of large volumes of dilute urine occurs. It can be caused by a defect in the production of ADH, advanced kidney disease, or hereditary factors. Renal calculi, or kidney stones, are crystals of salt precipitate which solidify to become insoluble salts. So in this image we can clearly see the presence of the renal calculi, or kidney stones. That concludes our section on the renal system.